Hello, Dr. Annie. Welcome to DC Conversations. So, first of all, could you tell me something about your career and what you've done so far and something about your profession?
Okay. Uh, I was always interested in genetics. In fact, from my high school days, when I read the first chapter called Heredity and Variation, and I pursued it. Although at the time when I was wanting to do genetics, there was very little genetics in medical colleges. Much later, clinical genetics started as a super specialty. So I did genetics. Then I did my PhD also in genetics. Did my earlier thing in Center of Cellular and Molecular Biology, which was one of the best places to do molecular biology in Asia. And subsequent to that, I went as a exchange scientist to New Zealand, where I worked at the Wellington Medical School. And initially, my career was focused on research, but I always was keen to bring genetics to the clinic. And I got this opportunity only in 2000, where I could start genetic diagnosis, genetic testing in 3 hospitals in Hyderabad after my stint in both New Zealand for 8 years and the US. What I wanted was that genetic testing as well as genetic counseling should become part of normal day-to-day healthcare. And for that, I realized that just, because in India, the genetic curriculum in medical school is very tiny. So there has to be somebody who liaises between the patients, families, policymakers, clinicians, and the genetic tests. And these professionals are genetic counselors. So I thought that I should, and in India, we didn't have genetic counselors, so I thought we should train. And I must say that Kamineni Hospitals encouraged me to both do the genetic diagnostics, the genetic research, and teaching training of genetic counselors. So since 2001, I'm attached to Kamineni, but we are doing training, teaching pan-India. So we do, every year I try to get people from different parts of India so that they go back and serve their states or their cities. But as you know, the way it happens is you want something, but the students want to do it only in the metros. So most of them are in Bangalore.
Yeah.
So now, as the genetics and genomics has advanced, and from 2014, in India also, we have various diagnostic labs which have come, where whole exome, panel testing, all that has come. So many people are now opting for it, and it is becoming part of mostly routine healthcare, seen in pediatrics, gynecology, oncology, neurology, and gradually all other specialties.
Okay.
So it's
So, I
heartening
mean,
to see benefits in clinical practice.
That's wonderful. So, I mean, before I move on to the next question, I just wanted to check since we are talking about genetic testing, why don't they make it part of every, health checkup? Like there is a master health checkup which includes everything, right? Why don't we have genetic testing as one of the, parameters there?
Yeah, I'm sure it'll happen. You have to realize that genetics came into the clinic in 2014. So naturally, anything new is a bit expensive. So it doesn't come in routine care. But now there are a lot of players, and also internationally, 2 aspects of genetics will come into routine care. And like you said, master health check. One is the whole exome, where They are now, the tests which we used to do for 35, 36,000 in
Mm,
2014 is now coming down to 18, 15, and internet and Ambani's and all in Reliance are now wanting to get into it, and they are claiming that they will offer it for less than 10,000 or 8,000. So as the cost comes down, we can include it
mm,
in international places like Iceland and all, which are small countries and more socialistic where healthcare is in. They do it at birth and
mm,
then integrate it with the electronic record so that they are able to treat it. The other thing which is very reasonable and should come into mainstream, like you are suggesting, is the pharmacogenomics. That is, people are taking so many medicines, but are
mm,
those medicines helping them? Are they harming them? Are they effective? Are they ineffective? So there's a pharmaco, and Kamineni has been doing it for transplant patients and cardiac patients from 2006 onwards. Other
mm,
hospitals, very heartening to know, are coming up with it, and we see, breakthrough things in newspapers that this hospital or that hospital is doing it. But we have been doing it in routine care. Like you see, if you do a transplant, whether it's a kidney
mm,
transplant or liver transplant, you have to give them a drug called immunosuppression. That immunosuppressive drugs permits the donor's organs to get accepted by the body
mm,
or by the recipient. This drug has to be given in the right dose, and this dosage depends on an individual's genetics. So if the gene metabolizes this drug too fast, then it goes away and there's not, and it rejects the organ. If you give it in it's too high, then it causes renal toxicity or liver toxicity because the drug is too high in your blood.
yeah,
So the right dose can be got by looking at the genetics of a person. And this we have been doing for a very long time, and it should be adopted. So pharmacogenomics, I think, will come first in our country because
mm,
it's a smaller panel of genes, and also it's easy for clinicians to accept it as a test.
yeah,
Like cytogenetics, now all pediatricians and gynecologists do cytogenetics without even thinking about it. There's infertility, they'll send for cytogenetics.
mm,
Delayed periods, they'll send for cytogenetics. Sperm failure, they will send for cytogenetics, like that. Or child with intellectual disability or congenital malady, they'll send for cytogenetics. So let's hope it'll. I'm hoping it happens in my lifetime that we can
yeah,
offer clinical exomes to people in a master health checkup.
yeah. So, how much of our health do you think is really controlled by our genes and how much depends on our lifestyle?
See, you have to remember that the genes, you are born with the genes.
Yeah.
So it is very commonly given as a analogy that the loaded gun is the genetics.
Mm,
Pulling the trigger is the lifestyle. So
right.
you can't change your genes, but you can change the lifestyle so that the expression of genes is modified. So genetics holds like we all know that if we take genes for height, there are several genes which control your height. But there's one major gene, FGF3. If
Mhm,
there's a problem or a variant or a mutation, which is commonly understood nowadays, we call it a variant. But if there's a mutation in that, then however nice your other genes are,
mhm,
with this gene, the person is a achondroplasia, a dwarf. Got it? So there are certain major things which we cannot control.
mm,
Quantitative things where the gene, single gene is not controlling the disease
mm,
and multiple genes are there, the lifestyle, diet, all that comes into it.
mm.
like similar things like vaccination. Like thanks to COVID, everybody now understands that if you take a COVID vaccine or have had COVID,
Mm,
all of us did not have the same symptoms, correct? Some
right.
had only a loss of smell, some had some fever, some had breathlessness, and some died.
Mm,
So the virus is the same, but it is our genes, the host genes, which make us respond to it or succumb to it. Similarly, COVID vaccination. There are so many things. The COVID vaccination is causing, blood clot, but it doesn't happen to all. It happens to some. So
mm,
those some are the people who have the genes which are giving them the thrombolyte, thrombolysis, which is giving them the clots. So the genetics, I think, plays a large role. Lifestyle and diet, other factors come into play mostly for polygenic traits. That is, traits which are controlled by a number of genes.
mm.
But one to one is all controlled by genes.
Okay. So, you these days you hear a lot of people say, I have thyroid, and then there's the obesity, which is a major problem these days. So, do you think these two are influenced by genes, or maybe what are the diseases that are caused by genes that could be
Yeah,
affected
like you
because,
said,
your ancestors had it?
yeah. See, if you see families, you'll be able to say this very easily that you'll see, okay, there are multiple obese people in a family.
Mm,
So that can be due to two causes that that family is not eating right,
mm,
correct?
mm.
Or that family is genetically susceptible to getting their metabolism is such,
Yeah.
their hormonal profile is such that they get it. Same with hypothyroidism. You are absolutely right. There is a theory that because we are using iodinated salt,
Mm,
this iodine plays a major role in the thyroid, and is that dysregulating thyroid synthesis? And are we getting more prone to hypothyroidism because of the excessive iodine we are taking?
mm.
Because iodine is required in a trace amount. Do we need so much of it? Got it? So that
Yeah.
comes with environment. But having said that, everybody doesn't get hypothyroid. And everybody's obesity is not because of hypothyroid. They
Yeah.
may be because of adipocytes. There. And obesity is not, although you call it a single disorder, but obesity can be because of your adipocyte regulation, your cholesterol intake, your hormonal dysregulation, your reproductive hormones. Uh, have you are you into gymming and all and leaving it? High excessive, so various things. So that is where I said that when multiple factors are causing a disease, then genetics and environment both play a role.
Mm, mm,
And there, that is where we are now. So that's why we also say nutrogenomics. You must have heard. There are two sisters. One of them says, I hardly eat anything and I put on weight, whereas she can eat a whole plateful of rice every day and doesn't put on. So that is where the genes come.
yeah.
That you have a genetic susceptibility, a certain genetic pattern, which makes you require a particular type of diet and which is sufficient for you. And if you take more than that, then you're going to put on. In fact, there's a very interesting theory about the Indian genetics. Indian genes, they say we have thrifty gene, means
Mm.
we don't require so much food. We are getting too much food nowadays. We used to manage with, yeah, we used to manage with less food, walk miles to get water, and our general geographic terrain was such that we walked so much. We did not eat too much processed foods,
Mm,
which now we're doing.
right.
Yeah. So, I don't agree about all the time blaming Western food. That's not right. Our food also is very fatty. correct? We
Yes,
also have
yes,
many
absolutely.
deep fried and fatty foods. So it is the whole idea is that you are supposed as an adult to take 2000 calories. Now how do you take it? If you are taking 2000 calories with having so many fried items, or you are dividing it into
A
your
balanced
protein
portions.
and
Yeah.
balance it, then it's fine. Or see, our sweets are more sweet than any western sweet, correct?
Correct.
So it is, yeah, so that's what we have to understand. It's processed foods. Naturally, processed foods are more advertised. Processed foods are easy, easy for working people. It's easy for a working mother to give in the lunch box for a
Mm, mm,
child.
mm.
Something to buy and give it, rather than making chapatis and rotis and pulkas and all that. You can just buy something and give it. So that way we are also, our lifestyle has changed.
Mm.
So based on lifestyle, based on the availability. So as a child, I don't remember ever going to a restaurant. It used to be a once or twice a year big event, for a New Year's party or some one day after Eid we would all go or something like that. But
Yeah.
now it is unheard of. Now every person who goes to school, I think, needs to take chips or biscuits or something which is, yeah. So it goes both ways, correct?
Right.
So if our meals, uh, in fact, I always joke about this, that we were having a consultant's party, and endocrinologist was sitting on one side and a diabetologist on the other, and I was sitting in the middle and having a gulab jamun, and my ice cream was sitting on the table. And one of my other friends said, "My God, you are brave, sitting in between an endocrinologist and diabetologist and eating all this."
Eating this,
So I
yeah.
said, "Okay." So I said, "No, no, don't worry. I have the good genes."
Definitely.
So that's it. Yeah. So I'm doing all the talking now. I have to wait to listen
No,
to
no,
what
I
you
mean,
want.
so these genetic disorders are always inherited or they can appear for the first time in the family?
That's an excellent question. Genetic disorders can occur for the first time also in a family
Mm,
because it is called a de novo mutation. De
mm,
novo means while the baby is developing, there's a lot of cell division.
mm,
Correct? When a baby develops from a single cell to multiple. So when the cells are dividing, there is a chance that there is an error in one of the genes. We have 20,000 genes. So, like at the time of division, if an error occurs, then that particular error in that particular gene causing a disease will be seen only in that child. It will not be seen in anybody else in the family before, and none of the sibs, but only in this child. But this child will then pass it on to the next offspring because that child's germline has this variation. And we see a lot of this in NF1,
mm.
NF1 mutation, which is, you may have seen people with a lot of nodules on the
Yeah, yeah.
skin nodule, yeah,
Mm,
on the face, on the hand. That is due to neurofibromatosis 1 gene.
mm,
NF1 gene somehow is more prone to de novo mutations.
mm.
So we see a lot, and they say nobody in our family has it. But once that person has it, then they pass it on to others. So there are a
Okay.
lot of de novo
So
autosomal.
if it is passed on, suppose if it's something like a cancer and somebody actually tests positive for a cancer gene, right? Does it mean they will definitely get cancer? And for how many generations can actually carry it?
See, it can carry for as many generations as they are reproducing, correct?
Hmm.
Because if I have the cancer gene and I'm not having a child, then that's where it ends with me.
Correct.
But if I'm having a child, then there is a 50% chance that I pass it on to my child. In
Yeah.
mostly cancer, hereditary cancer syndromes, that's the case. But
Mm,
once you inherit the gene, then your lifetime risk increases. It doesn't mean that you will get cancer tomorrow. You are
mm,
carrying the gene. Like for breast cancer, it is very well known BRCA1, BRCA2.
mm,
BRCA1, if you have, your lifetime risk of getting breast cancer is 80%.
mm.
Whereas for the general population, it may be less than 10%.
Yeah.
Correct?
Yeah.
Similarly, if you're BRCA2 carrier, then male getting prostate cancer below the age of 60 is about 60 to 70%.
Mm,
Risk of getting ovarian cancer till the age of 80. That is, if they live up to 80, their risk of getting that particular cancer is that much. But that doesn't mean that they have to wait till 80. Some may get it at 45, some may get it at 50.
mm,
And that is where people are still studying that are there some other modifier genes or is it the lifestyle? Correct? Because
yeah.
is lifestyle adding to it and causing a early onset of disease? And it can be pesticides, it can be, any grow hormonal triggers or the medication you have taken or contraception
Mm,
or spacing of children,
mm,
lack of lactation. So there come the lifestyle factors,
yeah.
which may delay the risk. And there's one more thing for colon cancer, Lynch
Mm,
syndrome, which is a hereditary cancer where people get colon cancer. And now they have shown that if you take aspirin from the age of 40 and you are carrying that gene, you will
mm.
delay the cancer symptoms for about 20 years.
Wow.
Wow. So you get that extra time. So that I hope I've answered your question that if you carry the hereditary cancer genes, your risks are high. And also, you remember, when you know it, you are put on surveillance.
Mm,
So you detect it early. Your
mm,
treatment options are better. You can also prevent it by doing lifestyle modifications.
yeah.
So knowing that you have a hereditary cancer risk is really beneficial. And that is something I think we should promote more than whole exome. That get your cancer risk done so
Yeah.
that you have a good quality of life, early intervention and prevention.
Right.
In
So
fact, you can
talking,
even do prenatal testing.
uh, so I mean, we are talking about genetic testing, like now there's next generation sequencing also, right? NGS. So what
Yeah.
can NGS tell us that older tests could not do?
Okay. See, our body is made up of cells. Each cell has 46 chromosomes.
Mm,
This chromosome number makes us humans. If it was 40, we would have been a mouse, or 20, we would have been a maize plant. So 46 makes us a human. So if you earlier tests looked at the chromosomes,
mm,
if the chromosomes are made up of DNA, and the DNA is regions of DNA is called the gene. So there
mm,
are 20,000 genes on these 46 chromosomes. I mean, 46 means 23 pairs.
yeah.
So now, before the test which we did, we looked at the chromosomes, which is karyotyping. So
Mm,
it told us several things. But now NGS enables us to look at all the 20,000 genes and their variations.
mm,
Now, the difficulty in that is that all gene changes or variations are not disease causing.
okay.
They are also, yeah, they are also important to make Rashmi and Annie. Correct? We are humans, but we are
Right.
unique. Each of
Yes.
us, yeah, looks wise we are unique, disease wise we are unique, metabolism wise. So this some of these variations are not disease causing, and that is where we are. That we are using bioinformatics to try to pick up those variations which are disease causing. Got it? And those variations which are important to make us unique. There are
Nice.
variations, but not disease causing. So
Yeah.
NGS enables us to look at all the genes.
Hmm.
The earlier tests enabled us to look at the chromosomes.
Okay. Okay. So one last question, which is very important, I thought. What do you think is an appropriate age for one to go through genetic testing? And I mean, are there different kinds of testing, or there's just one where, all the parameters are determined there?
No, there are different tests and different which can require to be done at different time points.
Mm.
Some are genetic tests, some are non-genetic tests, but can identify genetic diseases.
Okay.
Like pre-birth in the pregnancy,
Yeah.
there are the two tools, NT scan or a TIFA scan, which
Mm.
can pick up genetic disorders.
Yeah.
There is NIPT. NIPT is where you take the mother's blood sample and look for uh, anomalies in the fetus. So that can be done at certain stages of pregnancy only.
Mm.
NIPT, I won't do it for myself. I'll do it for somebody who is after 10 weeks of pregnancy up to whatever age we want. Then there is
Mm.
amniocentesis. Then there is newborn screening, where when the child is born, we can do a test, which is
Mm.
more biochemical but identifies more than 60 common diseases even before the symptoms come.
Mm.
Then comes if we find a problem like there is infertility or recurrent abortions, then we do the karyotyping chromosome test is the first test.
Mm.
Then if we find a child with a problem and we can identify that this is chromosomal, again we do cytogenetics, we don't do NGS. Like the most common thing, Down syndrome. Down syndrome is not identified by NGS, it is identified by karyotyping or CMA.
Yeah. Yeah.
So that is where the genetic counselors are very important because they help you choose the right test. Now,
Mm.
hereditary cancers. If you have a family member with young onset cancer or more than 2 or 3 family members with some type of cancer, then do the hereditary cancer test.
Mm.
Adult onset disorders, we say 18 years. You do the test at 18
Mm.
because they show the difference. But having said that, it is maturity onset diabetes of the young. Sometimes it comes at 17 years, 18. Then there's a panel of genes which we do then. Anybody want, I think all of us are going to use some medicine or the other. Then pharmacogenomic test can be done at any stage in life. It's not that you have to do it now or then. It's the earlier the better because then you will know what the uh, best treatment for you is. Like if you have a asthma, children have asthma. Is that
Mm.
drug that buffer he's taking it suits or not suits?
Yeah.
What's the response? Then there are, of course, detailed engine. But now there are countries who are doing the NGS or the whole genome or whole exome at birth.
Mm.
They're saying that saves more time and better diagnosis
Correct.
at birth. But then, as you know, we are a low resource country. We come in the thing, so we cannot afford to do it, and we also have a large population.
Yeah.
So we are not recommending it as a first line testing for babies. But
Yeah.
I'm sure it'll come. It'll come.
Thank you, doctor. Thank you so much for such an
Thank
insightful
you. It was
conversation.
lovely talking to you.
Lovely
And
talking
I
to you
hope
too.
this is useful. Bye bye.
Yes. Bye. Thank you, doctor. Bye.